Hello, a big greeting to all our international medical friends. Today, I will talk about polycystic ovary syndrome, overview and ovulation induction strategies, about current evidence. What current evidence we have? Polycystic ovary syndrome, PCOS, is a heterogeneous syndrome, is a family aggravation, is a peripuberal beginning. The etiology is unknown. The prevalence of PCOS in the general population is 20%. In the patient who had oligomenorrheas is 87%. The patient who had amenorrheas is 26%. And the patient who go to the ABF is 33 to 50%. The heterogeneity of clinical expression is that all of the patient who has PCOS is different. For example, the ultrasound morphology of PCOS is 70%, hyperandrogenism is 48 to 70%, the menstrual irregularity is 66%, and the obesity is 38%. All the patient is different. And the biochemical expression is the same, it's an heterogeneity. The testosterone, the LH, the LH-FSH ratio, the prolactin, the dihydroepiandrosterone sulfate, 17-hydroxyprogesterone and insulin resistance is different, different percent the patient experience. When we need to do a diagnosis, we need to use diagnosis criteria. Remember that we have three ways to do a diagnosis. So the more frequently used is Rotterdam. The criteria of Rotterdam is the consensus of European Society and HRM. It was published in 2003. Remember that include 2 out of 3 criteria: oligonovulation, hyperandrogenism, clinical or biochemical, and morphology of polycystic ovary with ultrasound. 2 out of 3 is the diagnosis if you exclude another pathologies. What pathologies do you need to exclude? Congenital adrenal hyperplasia, Cushing syndrome, androgen-producing tumor, exogenous androgen intake, Hyland syndrome, idiopathic hirsutism, hyperprolactinemia, and hypothyroidism. So if you look this, you can see a different way to diagnose the PCOS. For example, there are 4 phenotypes to diagnose. In this case, the phenotype 1 is a classic PCOS. You need to include the 3 criteria. When you say phenotype 2, it's an essential criteria of the NIH. It's just clinical or biochemical evidence of hyperandrogenism and evidence of oligonovulation. The phenotype 3 is the patient that is ovulatory, clinical or biochemical evidence of hyperandrogenism, and ultrasonographic evidence of a polycystic ovary. And phenotype 4 is the non-hyperandrogenic PCOS. So evidence of oligonovulation and ultrasonographic evidence of a polycystic ovary. The most frequently is the phenotype 1, and the second one is the phenotype 3. And less common is phenotype 2 and phenotype 4, but it's really often. When you are in front of the adolescents, you need to get 3 criteria. You need to hyperandrogenism, chronic anovulation, and polycystic ovary. Remember that the adolescence has great ovaries and a lot of follicles, but it's normal. So if you see hyperandrogenism and chronic anovulation, it's probable that you are in front of the PCOS. But if you have only 1 criteria, it's possible that it's not a PCOS. You need more time, for example, 1 or 2 years more, to try to diagnose the PCOS. The prevalence of PCOS is different. It's different because you use different criteria. If you use the Rotterdam criteria, the prevalence is between 14 to 19%. 74% of patients with PCOS are anovulatory, 30% of patients with infertility are anovulatory, and 90% of them are due to PCOS. The clinical expression is broad, and later complication is broad. The clinical expression is ambulation, menstrual irregularity, infertility, hyperandrogenism, obesity, obstetric complications like pregnancy-induced hypertension, recurrent pregnancy loss, and gestational diabetes. The insulin resistance, the risk factor for problems to glucose tolerance, is 3.7 times higher risk. 30 to 50% of obese women with PCOS develop problems with the tolerance of glucose. Diabetes mellitus by the age of 30 is 30 to 50%. The change of metabolic syndrome is 2-4 times greater than the general population. More than 50% by the age of 40s will develop metabolic syndrome. Another problem is development of markers of early cardiometabolic risk, obesity, reducing nitric oxide synthesis, increased vasoconstrictor synthesis, dyslipidemia, impaired glucose metabolism is 20-30 of the patient. Heart disease and myocardial infarction increases in menopause, 1.5 to 4.5 times. Atherosclerosis, early endothelial dysfunction, chronic inflammation, early increase in serum age level, the end product of application, and endometrial cancer and endometrial hyperplasia. Remember, all the time the cycle is a persistent estrogen. Estrogen is high every time, and the endometrium proliferate. And this is the etiology is difficult and is unknown, but there are some hypotheses to try to explain the PCOS. The neuroendocrine hypothesis is the LH increase. Basically, is the high pulsatility of gene RH that increase the LH pulsed, and the LH is increased. And the LH go to the TECA cells and stimulate the production of androgen. The ovarian hypothesis is a functional ovarian hyperandrogenism and altered steroid enzymes. Adrenal hypothesis is to high activity of some enzymes and high serum levels of adrenal precursors. The insulin resistance and hyperinsulinemia hypothesis is very important because it's the way to explain the cause to PCOS and is the way to explain what medicine we can use to adjuvant to get ovulation. I will talk about this topic in the next slides. Genetic factors, pro-inflammatory genotypes, and fetal reprogramming, intrauterine growth restriction, maternal fetal malnutrition, and androgen exposure. The objective of treatment in reproductive desire is to get monofollicular development. Start with the samples and less invasive handling option. Maximize the rate of single pregnancy and minimize the rate of multiple pregnancy, and minimize the risk of ovarian hyperstimulation syndrome in women treated with gonadotropins. This is the practice with greater cost effectiveness and evidence-based. What strategies we can use? The first strategy is to use clomiphene and letrozole. I will talk about more about this in the next slides. You can use adjuvants like metformin, myo-inositol, dexamethasone, and HCG. gonadotropins, and ovarian drilling by laparoscopic. Practice with greater cost effectiveness and evidence-based. When we talk about clomiphene, we need to remember that it's an older and widely used. Your mechanism of action is to selective estrogen receptor modulator. So in this way, the clomiphene bind to the receptor in the hypothalamic to estrogen, block this receptor, and the hypothalamic understand that is no estrogen in the serum, but try to compensate this and hide the pulse of generation. This pulse of generation stimulate in the pituitary to produce FSH and LH, and LH stimulate folliculogenesis and steroidogenesis, and finally the ovulation occur. This is the mechanism of action of clomiphene. The clomiphene classically start in day 2 to 5 with doses of 50 milligrams per day. This is the first doses. You can start in 2, 3, 4, or 5 days, the equal rate of ovulation and pregnancy and abortion. The monitoring, the ultrasound monitoring is between day 10 to 12 of the cycle, and follow-up ultrasound according to follicle diameter for indication of intercurrence programmed. The goal is the follicle between 18 to 22 millimeters. And 7 days post-ovulation monitoring with serum progesterone. The goal is to greater than 10 nanograms to deciliter, or ultrasound for ovulation verification, change in endometrial characteristic, presence of corpus luteum, and free fluid in Douglas. The ultrasound monitoring pregnancy rate is 48% versus 35% without echo. So I recommended that you use ultrasound monitoring for all patients when you decide to use medicine to induction ovulation. What is the response with the clomiphene? The rate of ovulation is 49%. The pregnancy is 30%. And live births in one cycle of 6 cycles are 23%. The cumulative pregnancy rate is 75% in 6 to 9 treatment cycles. The fertility rate decreases with age, and therapy is not recommended for more than 6 cycles. Remember that when you use for more than 12 months, the risk of endometrial cancer is high. They do not respond to 150 milligrams per day, so you can establish the resistance to clomiphene. It occurs in 20-25% of patients, but 52% will ovulate with 50 milligrams of clomiphene, and 22% will ovulate with 100 milligrams of clomiphene. So 74 patients can ovulate with 100 milligrams. And what about Cochrane library? Cochrane library compare anti-estrogens versus no-treatment or placebo. Your results was 5.9 times more pregnancy when we use clomiphene compared with placebo or no treatment. So the clomiphene improves the likelihood of a clinical pregnancy compared to placebo. And when we talk about aromatase inhibitors, we need to understand the mechanisms of action. We need to remember this piece of steroidogenesis. This is androgen and estrogen. This is aromatase enzyme. The path to androgen to estrogen need aromatase enzyme. And if you inhibit the aromatase, don't produce estradiol. So the body understand that there is no estrogens. If no estrogens, the hypothalamus understand to need to produce pulse of generation. The generators stimulate and pituitary to produce FH and LH. And finally, stimulate to folliculogenesis and steroidogenesis, and finally, the ovulation occur. This is the mechanism of action to aromatase inhibitors. It's indicated in women resistant to clomiphene or those who cannot use clomiphene due to side effects like vasomotor symptoms, visual changes, or headache. Women with thin endometrium less than 7 millimeters when taking clomiphene. Remember, the clomiphene has a problem with the endometrium that your effect anti-estrogen not permit to grow the endometrium. So this is the way to use letrozole. It may be the most effective oral agent for the treatment of anovulatory and explained infertility versus clomiphene. I will talk about more. I will talk about this topic in the next slide too. There are 3 regimens to use letrozole. One regimen is to start 2.5 milligrams in the day 3, 4, or 5 for 5 days. It's the same of clomid. The other regimen is to use 2.5 milligrams for 10 days, start the same days. And the third regimen is the single dose, 20 milligrams once at day 3 of the cycle. The current evidence indicate that use of dose of 5 and 7.5 milligrams does not offer any significant improvement in pregnancy rates over the lower dose of 2.5 milligrams. The significance of this is try to start every time with 2.5, but not with 5 or 7.5 milligrams. The ultrasound monitoring is the same of clomiphene. This is an example, the table of example. The use of letrozole is the same of clomiphene, starting 3, 4, or 5 days the cycle. And the first monitoring, ultrasound monitoring, is the days 10 to 12. The result in ovulation induction with letrozole is ovulation rate is 70 to 88%. Endometrial thickness is 7-9 millimeters. No adverse effect on endometrium or cervical mucus. The mean follicles is an average 1.7, is very good. No twins pregnancy, and the pregnancy rate is 20 to 27 per cycle. This systematic review and meta-analysis compare letrozole versus clomiphene. The results are live birth rate and pregnancy rate is 1.5 and 1.3 times more than when compared with the clomid of clomiphene. There were no difference in multiple pregnancy and spontaneous abortion between the 2 groups. Letrozole is higher than clomiphene when consider live birth rates and pregnancy rates in patients with PCOS. And what about coprine? When compare live births and clinical pregnancy rates, it's better with the use of letrozole with or without adjuvants. But the ovarian hyperstimulation syndrome and miscarriage rate is the same with the use of clomid or letrozole. What about recommendation of international evidence-based guideline for the assessment and management of polycystic ovary syndrome published in 2018? Letrozole should be considered first line. Letrozole, where letrozole is not available or use is not permitted or code is prohibited, you can decide another ovulation induction agents. The risk of multiple pregnancy is less with letrozole than clomiphene. And when we need to use adjuvants, we need to understand these mechanisms, the insulin receptor and second messenger, phosphoinositide pathway. In this picture, you can see the membrane cells. This is the receptor of insulin. This is insulin that binds to the receptor and activate the phosphorylation intracellular, let the vesicle to include the transportation of glucose, the GLUT4, to translocation to the membrane to catch a glucose, and internalize the glucose. The glucose internalized will take two ways. One is to storage the glucose in way to glycogen, or to use the glucose. Remember, if I cache the glucose and use the glucose, the insulin is low, but this mechanism is damaged, so the glucose is high and the insulin is high, so the hyperinsulinemia is the consequence. So I need to understand the second messenger, and the second messenger in this case is the inositol. The inositol is intake per oral in way to cereals and fruit. This inositol is included in the membrane cells in the phosphoinositol phosphate, and phospholipase C degrade this, and inositol triphosphate is running to the endogenous reticulous membrane to release calcium. This calcium is the explication to the vesicle translocation until the membrane. So this is the mechanism of inositols. We need to remember the double cell theory. This is the TECA cells and this is the granulosa cells. In the TECA cells, we found receptors to insulin, to IGF-1, IGF-2, and LH. So remember, if I found a high levels of insulin, stimulate the receptor of TECA and produce finally androgens. And the insulin high stimulate IGF-1 and IGF-2 and stimulate more produce of androgens. So this is the mechanism of produce the hyperinsulinemia to hyperandrogens. And the other theory, if you remember, it's a increased LH increases. So if you have increased levels of LH, you are stimulate constantly the producer androgenous of TECA cells. This is the other mechanisms to understand the hyperandrogenism in the PCOS. When you decide to use metformin, they inhibit the production of hepatic glucose, improve insulin sensitive, they decrease insulin secretion, total free and ovarian androgen decrease, increases spontaneous ovulation rate, and improve response to clomiphene. And what about Cochrane? About metformin for induction ovulation. When they compare metformin versus placebo, they conclude higher rates of ovulation and clinical pregnancy and adverse events. The evidence is moderate quality. So I know, we know that the metformin is not good to tolerate, but it's the reason to the adverse events. But the higher rates of ovulation and clinical pregnancy is very good. Live birth rates may improve slightly with metformin by limited number of studies. The evidence is low quality. When they compare clomiphene versus metformin, the patient who use clomiphene with a body mass index greater than 30, higher rates of ovulation, clinical pregnancy, and live births. The evidence is low and very low quality. Similar abortion rates independent of body mass index. The evidence is low quality. And they compare clomiphene versus metformin plus clomiphene. The patient who used metformin plus clomiphene, higher rates of ovulation, clinical pregnancy, and even advance, is the evidence moderate quality. There was no conclusive evidence of difference in live birth and abortion rates. The evidence is low quality. However, wider range confidence intervals and low quality of evidence make the advantage offered by metformin difficult to interpret clinically. And what is the real indication for use of metformin as adjuvant? This slide is very important for me. You decide to use metformin when you have clomid resistance, when you have resistance to low dose gonadotropins. when you have evidence of insulin resistance, the patient is obese, the patient is or has carbohydrate intolerance. When you decide to use controlled ovarian hyperstimulation for ABF, because reduce the risk of ovarian hyperstimulation syndrome, it's possible that increasing pregnancy rate, but it's not clear. Individual studies show improvement, but the RCTs fail to demonstrate that benefit. The dose is 1,500 to 2,500 milligrams per day, starting 4 to 6 weeks before the start of stimulation ovarian. So it's important to understand this because it's often to found a physician to use low dose, for example, 500, but it's not really useful. If he decided to use it as the only ovulation induction agent, it should be clarified that there are other more effectiveness agents for ovulation induction. In this review about inositols, inositol's importance in the improvement of the endocrine metabolic profile in PCOS, in the excess androgen, reduce total and free testosterone levels and LH with increased HBG by improving the myoinositol-dechiroinositol ratio. In ovulation disorders and infertility, increases ovarian sensitivity to FSH with resumption of spontaneous ovulation cycles. It increases glucose uptake by the cell, improving oocyte and embryonic quality with increased fertility and pregnancy rates, and reduction in risk of ovarian hyperstimulation syndrome. When you talk about the morphology in the polycystic ovary, the elevated levels of anti-Mullerian hormone decreases the sensitivity of the follicle to the FSH and decrease the activity of aromatase. Inositols improve the sensitivity and activity of aromatase. In the metabolic abnormalities, improve glucose insulin ratio and HOMA index, increase HDL with reduced triglycerides and LDL, weight loss and reduction of leptin, improved insulin resistance, and decreased blood pressure. These meta-analyses of 9 RCT about myoinositol effects in women with PCOS conclude that decreased fasting insulin, HOMA index decreased, reduction in total testosterone, increased levels of SHBH, especially after use of 24 weeks, not what's observed with the use for 15 weeks. They conclude myoinositol alone or combined with dechiroinositol improves the metabolic profile in women with PCOS. And what about recommendation of the guideline? Inositol, inositol in any form should currently be considered an experimental therapy of PCOS. And what about recommendation of gonadotropins? Gonadotropins could be used as second line. The gonadotropins could be considered as first line when the physician is a good physician to using gonadotropins to counseling in cause and potential risks of multiple pregnancy. The gonadotropins is a second line with the clomiphene citrate resistance. And if you decide to use gonadotropins in the patient with clomiphene citrate resistance, you need to addition of metformin is better. Finally, to discuss about something to laparoscopic ovarian drilling is the second line treatment to induce ovulation. It's indicated in clomiphene resistant, in resistant to low dose FSH, in patients who persistent LH hypersecretion, in thin women, in need for pelvic evaluation, for example, in patients that we suspect that has adhesions or endometriosis. In patients, it's difficult ultrasound tracking, but live remote. Factors that influence the response to LOD, elevated concentration of LH and anti-Mullerian hormone have been associated with a favorable response to LOD. Increased body mass index, marked hyperandrogenism and long duration of infertility have been associated with unfavorable response to treatment. This picture is interesting because you can see the spontaneous ovulation in average age 26 to 92% is the effectiveness, and the pregnancy is between 20 to 92% in different studies, so it's interesting. The technique is monopolar or laser. The technique is 4 punctures for 4 seconds per puncture, 4 to 10 millimeters deep, 40 watts is the rule of 4. And unilateral, dropping Douglas with 1000 millimeters of saline. The use of bipolar increased ovarian tissue demise for its no-use police. The disadvantage is surgical procedure, obviously, although minimally invasive. All possible complication of a laparoscopy, but is less than 1%. Periovarian adhesion in 46 to 70%, mainly in the left ovary, regardless of the number of puncture. It's interesting. Reduction of ovarian reserve or restore normal reserve. The cost is 5 times more expensive than a stimulation cycle with FSH. And what about Cochrane, about laparoscopic drilling? When compared as the first-line treatment laparoscopic drilling with another medicine to ovulation induction, the live birth and the pregnancy rate is the same. And important is the multiple pregnancy rates and ovarian hyperstimulation syndrome is less than the other medicine to get ovulation. So it's interesting. And the question, unilateral or bilateral laparoscopic ovarian drilling, this meta-analysis conclude that after carefully weighing the known benefits of bilateral laparoscopic ovarian drilling against a possible risk to ovarian reserve, it may be advised to unilateral laparoscopic ovarian drilling achieve the same result in infertile patients with clomiphene-resistant PCOS. And what about the guideline? Laparoscopic ovarian surgery could be second-line therapy, but laparoscopic ovarian surgery could potentially be offered as first-line treatment if laparoscopy is indicated for another reason. For example, if you suspect adhesion of endometriosis. ABF is a third-line therapy where first or second-line ovulation induction therapy have failed. The algorithm of guideline say a first-line no pharmacological management of infertility, lifestyle intervention. Really, I don't talk about lifestyle intervention, for I need to remember. So the first stone to management of the PCOS is the intervention of lifestyle, nutrition, diet. The first-line pharmacological management for infertility, letrozole is considered a first-line therapy, especially in women thin, in clomiphene citrate, especially in obese, clomiphene citrate plus metformin in the patient who had indication for use metformin alone, and gonadotropins. But if you decide to use this first line, but it's no, you don't get the goal, you can use second-line pharmacological surgical management, gonadotropins or laparoscopic ovarian surgery. Remember what is the indication of laparoscopic ovarian surgery. And the third-line management could be other appropriate intervention, including ABF. I really like this slide because summarize all the conference. So the first line of no pharmacological management always assess and or evaluate the nutritional part. You decide to start medicine, the first line of pharmacological management is letrozole or clomiphene. If you have resistance to clomiphene, add metformin, especially in overweight or obese patients. And 2, add dexamethasone, especially in thin patients, or switch to letrozole if you started with clomiphene, or switch to gonadotropins or LOD. Keep in mind, every time indication for metformin use, not indicate it has a salt or first-line agent. Second-line strategies is gonadal pins and laparoscopic ovarian drilling. Keep in mind indication of laparoscopic ovarian drilling. And third-line strategy is ABF. So the final question is inositols. In every patient with PCOS? Okay, so thank you very much for your attention, and I will hope to meet with you in early. Bye-bye.